CDX is proud to be supported by AMBOSS, a medical education platform with an expansive resource library and USMLE-style question bank.
Hello and welcome to 10 Clinical Minutes. I'm Brianna, and today we're going to be talking about cardiac stress tests. Chest pain is an extremely common problem that we see in both inpatient and outpatient settings. You'll hear the term typical chest pain thrown around, and this is actually a very precise term. Key characteristics of typical chest pain in a medical situation is substernal, aggravated by exertion, and relieved by rest or nitroglycerin. Typical chest pain has all three of those characteristics. Atypical chest pain has 2 out of the 3, and non-anginal chest pain has 0 to 1 out of 3. This terminology allows for more clear communication between physicians or other providers as to what exactly the characteristic and type of chest pain is that the patient is reporting. The reason why the classification of typical, atypical, or non-anginal chest pain is so important is because it helps us to determine the pre-test probability of coronary artery disease. This is a pretty complicated table, but I want you to look at it in chunks stratified by the type of chest pain. Typical angina is obviously the most high risk as far as the patient's risk of CAD or coronary artery disease, but that also is stratified by their age and their gender. The younger the patient is, the lower their risk is, but with typical angina, you never get less than intermediate risk. Atypical angina gets a little bit more complicated. It's important to note that anyone above the age of 50 with atypical angina has intermediate risk. And then finally, non-anginal chest pain has a lot more variation to it, and it largely depends on the patient's age and gender. The reason why these classifications are important is because the pre-test probability determines their risk of coronary artery disease and the most appropriate next step in the workup of this chest pain. For patients at high risk of CAD, you can automatically go to a heart cath procedure, where they inject dye to look at the arteries and see if there's any critical stenosis. Someone with an intermediate probability can undergo a stress test, which we'll talk about more in the following slides. Someone with a low probability can just do clinical follow-up to see if their chest pain resolves. And someone with a very low probability doesn't need any more workup. An important thing to note here is that women are historically underrepresented in the studies that produce this data, and so they may have a higher rate of the atypical symptoms but have true ischemia. And ultimately, your clinical suspicion is more important than some sort of a classification scheme. If you have really high suspicion that a patient has coronary artery disease, you need to take your clinical judgment as priority and do the type of workup that is deemed necessary for that patient. So some indications for stress tests. If your patient is symptomatic and they have intermediate risk, like that table we just talked about, they can get a stress test. If a patient has unexplained syncope and they have intermediate to high risk based on their age and risk factors, they would also need a stress test. Sometimes there are perioperative indications before a big operation for someone to get a stress test just to stratify their risk. This would be for someone undergoing a cardiac surgery, or if they're doing a non-cardiac surgery, but they can't tolerate more than 4 METs of exercise. So this is kind of a jargony thing. A MET stands for metabolic equivalent, and 1 MET is the amount of energy that you would expend just while resting. 4 METs of exercise is commonly described as being able to climb 1 flight of stairs. And if your patient can do that without chest pain symptoms, then if it's a non-cardiac surgery, they don't need a stress test. There are many contraindications to stress tests, but these all boil down to your patient having either active cardiac pathology or a stroke. That makes intuitive sense. If your patient's heart is already stressed or has something going on with it, you're not going to want to put it under extra stress. And if they have a stroke going on, you don't want to compromise the blood flow to the brain. So how do we actually do a stress test? Well, there's 2 main parts to this. You stress the heart, and then you look at the heart. To stress the heart, you can either do exercise or pharmacologic stress. Exercise is by far the best if the patient's able to exercise. It gives us more information about their functional status and their ability to exercise. Usually we do this with a treadmill with a progressively increasing incline according to a particular protocol, but you can also do bikes in some situations. Pharmacologic stressing usually uses one of 2 different agents. One agent is regadenoson, which is similar to adenosine, but it's more selective in that it only hits the receptors in the heart, so it doesn't cause all the extra side effects that adenosine would cause. The other one is dobutamine, which is a beta-1 agonist. But you need to note that dobutamine can trigger arrhythmias. So if a patient is, for example, admitted with AFib, you don't want to use dobutamine. After you trigger the stress, you need to look for ischemia. The signs and symptoms of ischemia are really important and can be the limiters of a stress test. You look at their peak heart rate and blood pressure, as well as any symptoms that they have. And then the EKG is done in all types of stress tests, and you look for any sort of ischemic changes like ST depressions or T wave changes. The type of stress test you choose depends on whether it's an echocardiogram or a myocardial perfusion imaging MPI. Echocardiogram you might be used to just based on the wards, and it's an ultrasound of the heart. With an echo stress test, you're looking for wall motion abnormalities with stress, and you're also estimating the ejection fraction and any other structural abnormalities that you see, comparing the heart at stress and at rest. Myocardial perfusion imaging, or MPI, is a nuclear medicine study looking for perfusion defects, specifically looking for asymmetry. That's really important for interpreting these, knowing that you're looking for differences in the relative amount of perfusion in one part of the heart versus the other. So how do we interpret the results of a stress test? Well, let's go one by one. So starting with exercise, the first thing you need to look at on the stress test report is the exercise duration. This is important because it tells you how accurate the test actually is. You can have a patient that may have had a quote-unquote normal stress test, but if they were only able to exercise for a minute, then that actually doesn't tell you a whole lot. You may see listed on the report how far in the Bruce protocol your patient got. And the Bruce protocol is basically just the way that the technicians will slowly increase the intensity of the exercise. So you can look this up if you want to see exactly how far the patient got if they list on the report when they had to stop the stress test. Exercise stress tests will go until fail. So they'll push the patient as hard as the patient can take it until they have symptoms or other signs of ischemia. As with all stress tests, you'll have EKGs at baseline and at stress, and you're looking for ischemic changes. And then on the report, you'll see reported a Duke score. This can be kind of confusing, and I think it's better just to be able to look up the numbers because otherwise you might get it mixed up. But the Duke score is calculated by the exercise time in minutes minus 5 times the ST deviation minus 4 times the angina index. And the angina index is 0, 1, or 2. 0 being no angina during stress, 1 being non-limited angina, and 2 being limiting angina, meaning that they had to stop. That calculates a Duke score, which then risk stratifies the patient. And there are a variety of studies that link a particular Duke risk with annual mortality from CAD. Higher is better on the Duke score. So a positive score is better than a negative score. The more negative you get, the higher risk the patient is. If we do an echo stress test, what we're looking for is wall motion abnormalities. You'll commonly see graphs like this on the stress test report. And what this is doing is showing you different cuts of the heart and stratifying it into different segments. And each segment of the wall is given a score on how it moves. So it can be normal, hyperkinetic, hypokinetic, akinetic, dyskinetic, or aneurysmal. What you're looking for in this is the severity of the wall motion abnormalities, if it's diffuse, meaning the entire heart, and if it's in one part of the heart, is it in an identifiable distribution of a known coronary artery? If so, then that clues you in that it's probably that artery that's occluded. And then interpreting an MPI, or a myocardial perfusion scan. For MPIs, you can order a SPECT or a PET. These are just two different types of nuclear medicine scans, but for non-cardiologists, they're pretty much the same thing. There are some technical physics differences between them, and the SPECT is a little bit cheaper than the PET, but for the most part, just need to know that it's a nuclear medicine scan for an MPI. You don't need to know the details of it. When you have an MPI, they cut the heart into these 17 different zones, and they look for the differences in perfusion to these different zones relative to each other. Each zone of the 17 that the heart is cut into will be given a score from 0 to 4. The increasing score has more significant defects in perfusion. Each area of the heart is given a score at rest and at stress. The sum of all the scores together during stress is the sum stress score, and the sum scores at rest is the sum rest score. The sum stress score is the most important as far as telling us perfusion defects for a risk of coronary artery disease. A score of less than 4 tells us that there's pretty much no clinically significant defects. The higher you go, the more abnormal it is. So in summary, for a cardiac stress test, you need to induce ischemia and then look for ischemia. To induce ischemia, you can do exercise, regadenoson, or dobutamine stress testing. To look for ischemia, you're always going to do an EKG and look for ST depressions, T-wave inversions, or other signs of ischemia. And then on top of that, you can either do an echo, where you look for wall motion abnormalities, or you can do a myocardial perfusion scan, where you look at focal perfusion differences between different areas of the heart. Here are some references. Thank you so much for joining us on this episode of 10 Clinical Minutes. If you have any feedback for us, please email us at info@decodingdx.com. Please like and subscribe. Thank you so much. We'll see you next time.